In this lesson, we're going to talk about domestic violence, how it impacts people working in healthcare and related fields. Now, domestic violence is something that people are pretty familiar with, at least have a general idea what it is. Our text doesn't exactly define it as state something about it. It says it's a complex social problem that carries serious healthcare consequences, especially for intimate partners and others in society. Now, a form of domestic violence is intimate partner violence. So, domestic might imply that the people have to be living together, although that's not necessary. And many of you listening have, you know, have witnessed domestic violence either personally or know someone who has. And so it could be in the form of physical violence. It could be verbal. It could involve keeping someone from going where they want to go. It could come in a lot of forms, but the key part of it is that it is in a certain kind of domestic sort of situation and does involve violence. Now, there are various things that can get in the way of someone working in healthcare dealing with someone who is a victim of domestic violence. And this could lead them not to be able to provide as good a care for this person as they might wish they could provide. Um, One of the things pointed out by the author of this text chapter is that uh, what has happened to us in the world, our experiences, shape how we view things. And also, we have certain assumptions about the way the world works. Now, the author makes this point several times that we may have grown up in a world in which social roles are very gendered. And that is, it's thought that there are certain roles that women play and men play, and that a lot of our uh, views on what's going to be happening in the world is shaped by this social construction. Um, so those assumptions and experiences are something we certainly have to take into account whenever we're dealing with someone who's a victim of domestic violence. Also, if you yourself, uh, as a healthcare provider, have experienced domestic violence or know someone who has, um, then merely listening to someone recount this experience may act as a trigger for you and make it more difficult for you to adequately provide for the patient. So again, these are things that have to be taken into consideration and that really have to um, teach oneself, have to learn how to, uh, I don't want to say repress, but at least understand that one has those things. Because if something triggers us, there's not a lot we can do about it a lot of times to stop the triggering, but we can stop and learn to stop how we react to that triggering experience. Now, in addition to these personal and social barriers, there are systemic barriers to providing adequate care to victims of domestic violence. As the name implies, these are problems with the system itself in which one is working. So, for one, healthcare providers often lack training in dealing with domestic violence related situations, and this goes from doctors to nurses, nurse practitioners, and other people who are healthcare providers and work in healthcare, that they really don't know what to do when confronted with this, and maybe they don't feel like it is their job to deal with this, that they would treat the symptoms uh, in these cases and not the cause. Um, and also that, similar to the previous discussion on personal assumptions, a healthcare organization itself might have certain assumptions about power arrangements in terms of gender, and that this might have cause people to have assumptions about the roles of men and women in society in terms of aggression or passivity or other such things of that nature. And again, maybe you wouldn't be able to change this from the ground up or from the top down, but at least something to keep in mind that this may be the case. Other barriers that might arise when trying to adequately treat someone who is a victim of domestic violence arises due to theoretical constraints on thinking. One idea that's discussed in the text is what they call medicalization of social problems. It's an idea that, from a clinician's point of view, that everything that's wrong with a patient has a clinical diagnosis, and that's not always the case. Not all social problems have such a diagnosis. The person exists and lives in a much larger context, and it's not merely their physical body and its effects, say, on their psychology that is at issue. Also, there are mental health models, and psychoanalysis is mentioned here as not being adequate, although I'm not sure how widely used that methodology is anymore. The main idea I think made in this section is that an individual cannot be removed from their lived experience. And there's an interesting discussion of trauma theory here, and most people will be familiar with the term post-traumatic stress disorder, or PTSD. And the idea is that someone has been traumatized by some event, and this affects them psychologically and, of course, manifests physically as well. Um, One problem with this model is that it tends to treat the um, trauma as something that happened in the past and is affecting people in the present, rather than seeing the trauma as perhaps something that is ongoing and may continue to happen, that it is not just a past event that's affecting the present, it's a past, current, and future events that will continue to affect the patient. So again, this stresses the idea that we have to look at the complete context in which a person lives and experiences their life. A related issue is inadvertent re-traumatization. The last thing a practitioner wants to do is accidentally re-traumatize a person who's already been traumatized, but sometimes entering into a system in which a person feels perhaps controlled or treated as an object, or in other ways not treated in a way that completely honors their autonomy, can cause them to be re-traumatized. So it is just a continuation of the ongoing trauma of the domestic violence. So the author discusses changing theory uh, in order to incorporate context into theory. And this seems like, given the previous discussion, that these are things that have to be done, and perhaps relates to the idea of treating a patient holistically, the whole person, and not just the person as a biological entity, but as a whole person who lives in a complete environment and has a lot of connections to a lot of other people, as does the care provider. There are also structural constraints that could get in the way. The fact that healthcare costs money and time, and that these things are often constrained by insurance companies and Medicare and Medicaid as well. Resources have to be allocated in a way that's fair, but also meets the legal standards that are there in place. And so this may be a problem with treating a victim of domestic violence when it seems as if, well, this may be causing some of their health problems. At the same time, this is not perhaps our job to be treating that. And of course, that creates a structural constraint in trying to treat the whole person. And The stigma associated with substance use or abuse and mental illness is also mentioned in this context. Um, Perhaps the stigma associated with um, mental difficulties, which you may call mental illness, that the stigma is becoming lessened as more and more people are willing to seek out counseling and therapy and other forms of help for their mental difficulties. Uh, Same with substance use. People can be using substances as a way to mitigate the suffering that they themselves are undergoing, and may use substances that are not legally prescribed to them for such uses, um, including alcohol, cannabis, opioids, and other such substances. And there may be a tendency for a care provider to um, look um, down on someone, maybe accidentally, who is using such substances, since it often does involve engaging in illegal activity. Well, given all these barriers coming from the individual who is the care provider to the institution itself to the training and on down the line, what can be done to improve things to better serve the victims of domestic violence? Of course, people could be better trained. That's generally always the solution to these kind of things, and it requires knowledge about what are the best practices in order to train people better. So, of course, that requires a lot of work and a lot of effort, and may require use of more money and resources that, including the time that people need to have to do these kind of things. People who are already often very busy with their work and other obligations. Merely showing concern may be a first step. And of course, we may all be concerned and um, for someone who's experiencing something like this, but they may need to know that we are concerned, and maybe we don't always show it. Maybe we feel like we're going too far when we show it, but at least letting them know, hey, we're here, I'm here, and we want to help. We understand as best we can what you're going through and would like to make things better for you insofar as we're able. And to do these kind of things, you need the support of the institution. You need the money and time for training. You may need to hire people who are experts in certain areas, depending on the size of your organization. Um, Showing concern doesn't cost money per se, but it may cost time, and it does, of course, require the support of the institution for which you work. But at least heading in this direction and realizing domestic violence for what it is and how it impacts people's health negatively, these could be first steps towards treating what is a very large problem throughout our country and the rest of the world. Okay, so that ends this lecture video on domestic violence. Thanks.